On behalf of the Peripheral System, welcome to today's webinar. We're glad you joined us and wanted to point out some of the buttons on the bottom of the screen. There's a Q&A button, so at any point during today's presentation, feel free to ask a question. We'll do our best to answer it during the webinar, and if there's not time to answer it during the webinar or you're watching it on replay, we'll be sure.
All right, hey everybody, this is Dr. Scot Sorum up in Bellevue, Washington. Today we're going to talk about posture patterns, how to identify them. Why is it important in our overall health? How is identifying a posture or a poor posture in a patient a predictor of probable future health issues? So why is rehab important for posture and spine correction? We're going to cover what affects posture, has on health, as I said, how to change these common postural patterns, how to improve them, how to get them stronger, what initiates the events for most people with poor posture, and then what do compensated subluxation patterns look like and how do they occur? So without further ado, here we go. So when we look at posture, we have most commonly, we look at from the side or lateral posture, or A-P, or frontal posture. It is how we hold our bodies up against gravity. So if you have good posture, you stand erect, you tend to look more confident, thinner, all these cool things. But if we have poor posture, it means there's an underlying deficit or there's been some type of injury that has caused the structural system, the muscles and ligaments that hold us upright and move us to fail or operate less than optimal level, is what I'm saying. So if you look at the lady in the picture, bad posture on the left, good on the right. We, with Peripheral system, will utilize identifying the postures properly, then weighting the patient accordingly to start reprogramming the neurology, which then will have a more permanent change, a lot like an orthodontist does using braces. So you can look at the diagram there in this next slide. We'll see this really commonly. Like this is a great graphic because I did this yesterday with a young lady who had a high shoulder and she's scoliosis and she was just hanging this bag, her book bag, off that shoulder. And I explained to them, I got her in front of the mirror and showed her so she got a visual map of what was going on with her posture and how it was affecting her. And I think for a lot of us, you need to utilize the ocular writing reflex, which is another Burrow-ism or something Burrow has taught us for years, that you get them in front of a mirror and you show them what their posture looks like, how it's poor, and what good posture looks like. So you start firing an image into the brain as to what it should look like, then they equate how it feels. Okay? So we know brain controls everything in our body. We've talked about it for years, but taking it a step further, we want to look at how stimulating the reflexes or incoming information and then effectively changes posture permanently and long term. Okay, because with poor posture, it's very much an indicator of somebody, as I said, who's more than probably going to have issues with their health in the future. Here's a quick study. So number 2 thing on this list, forward head posture. The body follows where the head goes. I learned that in martial arts a long time ago. If I have control of my opponent's head, is through his vision or manually, I've got control of his body. So if the head goes forward, which is one of the things we'll talk about, the initiating event, the body will eventually follow. Okay. So patients come in most commonly, the head's shifted off to the side, they have high shoulders rotated. You got to look at the orientation of the head position to the shoulders to the pelvis, and then in both AP and lateral planes. Common things we see, there's our common pain syndromes: head, tight shoulders, headaches, neck pain, shoulder issues because you've got a shoulder that's compensated and now rolled in because all their flex are dominant, and that started with the head being forward. There's all these things are influenced by posture. If you have looked at Dr. Callier's work, there's a great brochure on forward head posture, which I'm sure most of you have or have seen. I give that to every one of my patients because they get to start to understand how it affects their physiology. And long term, with decreased oxygen to all the cells of the body, they are not effectively healing as fast as they could or can, and or regenerating tissue. So it's very important to get this forward head posture corrected, and then we work, working on the shoulder and pelvic balance as well. So poor posture to good posture. Freeman found that shifts in the body center of mass or center of gravity cause these postural deviations. Intestinal issues are very common, especially with our scoliosis patients. You see decreased blood flow, obviously numbness, tingling, cold hands, cold feet, and they're all, down the river, so to speak, from where the cord and or nerve root compression is going on. And it does affect lifespan and their quality of life. Even if they live a long time, people that have poor posture, if you look at old people and they're bent over like this graphic on the left, they're not out running a marathon. They're typically on a lot of medications. But you see the people that have better posture as they age tend to be more active, more vital, and have a better quality of life. Core talks about this long-term increased activity in the sympathetic nervous system and how it is harmful to the body in general. It affects all of our sympathetics, the organs that are attached. And again, we look at structure. Structure in the human spine will always dictate function, i.e. bad posture, bad function. Bad function, organ dysfunction. So poor posture induced tension leads to decreased blood flow. We just talked about that, which means if you have less blood flow and your forward head and you're not breathing, you're a shallow chest breather, you're not getting enough oxygen into your system. Therefore, you can't oxygenate the tissues because you got nerve pressure affecting the blood flow, and now you're not getting as much oxygen along with the volume of blood. So you have tissues that are not able to combat aging process or disease process as well as they should. Dr. Callier, I mentioned before, we need the lordotic curves in our neck and our back, low back. Cervical and lumbar are necessary for proper function at our optimal level. We can still function with a kyphotic spine, but not very well. And most people at that state are in a state of chronic pain. And the body at first, when we talk about like a lateral posture, which we'll get into, you'll see the hips at first will be uncompensated, meaning the hips will be behind the head and shoulder girdle. And over time, they will compensate and come under. And you'll see this degenerative posture going on. Okay? A lot of stuff on Callier. Again, I would encourage you get the brochures on forward head posture. They have references to these different pieces of information that he found with forward head posture. So go into that. I'm not as a whole bunch of details. You're better off to read it and then educate yourself and educate your patients. Okay, and use that as a tool. Again, with our report of findings packet, we give that forward head posture brochure to every new patient. Okay, it alters the spine. You see this graphic is great. I mean, I've had multiple generations of ladies in here, and you'll look at this change, and it's not necessarily genetics, I believe, as much as is environmental influence. When you look at mom was exposed to grandma, child exposed to mom, and if they have a poor postural pattern, we've taken pictures of these generations, and you'll see a very similar structure. And I don't believe it's just genetic. Again, I think there's a lot of postural influence through the environment that they're in. When you have poor posture, you lose the ability to function properly at the shoulder and hip girdle, your knees, your ankles. So by losing that curve, you're elongating the spinal cord. And your ocular writing reflex always wants to keep your eyes forward. So if you look at this graphic, he's pointing down because he's getting really hunched over on that far right. But for most people, even the young people who see their head goes forward, but they tilt up. And that will lead us to talking about the initiating event here shortly. Spinal cord is connected to foramen magnum, it goes all the way down to the filum terminale, right? So if we have postural displacement, for example, injury, lateral impact, whether it's car accident, fall, if it's scoliosis, if we have somebody who sits constantly and they're in a bad posture, you'll see lots of people that spend 6, 8, 10, 12 hours a day in front of their computer, And as they get tired, they'll start to lean toward their mouse. Well, now they're starting to train the neurological pathways, and they're essentially training a muscular imbalance, a spinal imbalance into their posture, which leads to long-term dysfunction. And when we lose lordotic curves in both cervical and lumbar, we start to create a functional lordosis, or excuse me, a functional stenosis, which then over time can, as it becomes more pronounced or even kyphotic, you're causing permanent pressure on the spinal cord that can create permanent damage. Okay, and if you are in some type of injury, you will actually tend to get hurt worse than if you had closer to normal mechanics. Again, I've seen that with a patient. They went through the whole system of care, and say a year or so later, they were in a car wreck. And we came in, did a full workup, did a full set of films again that we did in the initial, and they were actually biomechanically stronger than when they first started, because we restored a lot of the normal structural curvatures and restored some of the normal elasticity to the ligaments themselves, and definitely they were stronger from a muscular standpoint. So functional stenosis, what does it do? Affects your cerebrospinal fluid. Why is that important? Well, we need to circulate that up through and into our brain. And with our deep diaphragmatic breathing, and when your head is where it's supposed to be, with a good curve in your neck, you get more oxygenation. You're more alert. The brain is stimulated, if you will. Again, a lot of stats here. We're talking about what happens with loss of spinal mobility. Well, the initiating event is skull locked in extension malposition. You get compressive loading, which over time will lead to degenerative changes, joint and disc, right? If you don't do something, you'll have permanent damage. This is where patients that come in, they're in chronic pain. We have to go slow with them because there have been osteophytic changes to the end plates. We've got arthritis in the posterior facet joints, and we have to go slow. I mean, can they get stronger? Can they improve function? Absolutely. I mean, my oldest patient was 95. The guy's bent over. In 6 months, he's like 2 inches taller, and he's standing upright and moving. And he said, "Yeah, I'm done with care," because he wanted to go live the rest of his life. But the ability for somebody who's that age to come in and have restoration of function is amazing. So amazing. Well, imagine what we can do for younger people. You know, they don't have to have these type of degenerative changes happening in their spine. So what happens when we lose mobility? Structures affected, bones, right? Muscles are affected. If you don't use it, you're going to lose it, right? So most commonly forward head posture, anterior neck flexors become very weak. We need to get that balance back. So we start working on strengthening. Increases in heart rate. We decrease our lung volume. That is another thing that we chart and test on a regular basis with all our patients, that we take spirometry readings. And I mean, I harp on them about deep diaphragmatic breathing, especially when they're doing traction and wobble. They need to start retraining that diaphragm to work properly. Some of the peripheral issues that happen, well, if you have somebody that has extension malposition of the skull, a lot of times they have rotation in the atlas and axis. And I use the analogy as like if you've ever taken a dish rag and you wring the water out of it, that's essentially what's happening, because you've got this slippage with the occiput coming forward, and then you have this torquing that goes on with atlas and axis, or both, which can create a myriad of issues from a symptom standpoint. And that's why when I talk with patients and they ask about, well, this hurts, or they comment, this hurts, but I've had this all my life or for many months, I listen, and then it's like, okay, we need to change some things. If you're ready to change, then we have to start working. So we can change a lot of this. You get rid of the nerve root compression, the vascular compression, just by opening up that skull, and that's what we use the negative Z for, right? It's pretty amazing the changes you'll see with someone that, as you start unlocking that skull, changing what had caused this and reversing that, their life starts to come back. So very common entrapment is the greater and lesser suboccipital nerves as they pass between occiput and C1. Headaches of all kinds. Suboccipital as they get temporal, they get into the jaw, they start to, if the head goes forward, people tend to start, you'll see a lot of clenching, a lot of teeth grinding, right? And then you are dealing with TMJ, which could be the cause of the headache as well, but, or the secondary cause. We go back to the primary, which is that initiating event, subluxation of the skull, locked in extension on atlas. So produce the following entrapments. So suboccipital peripheral entrapment, neuropathy patterns of head and neck. Here's a whole list of things that you will find, and they will start by and large, depending on how long the patient has had them, they will start to change on their own because our body is self-healing, self-regulating. We just have to unlock that skull, and we'll do other therapies, other adjustments to help speed that along. But most of these are not do not need to be medically treated. The body can do it. We just have to unlock that skull and get the head back, which is what we use the head weights for. So here's normal. Here's optimal. If you look at this diagram, normal weight bearing in front of the ear, through the shoulder girdle, L3, and right into the femoral head from the lateral version. If you drop a plumb line between center mass of skull, we should see that spine really close to that center line, if not right on it. That would be normal. That's what we strive for. From a postural corrective standpoint, we strive to be here in this diagram. Most of us, though, we have this forward head posture, right? With posterior pelvic tilt. You can see the gentleman's, his hips are behind his head and shoulder girdle. This is what we call an uncompensated. So his hips have not shifted under. This person, if they don't shift over time, they tend to have a lot of acute low back issues, okay? Your acute pain patients. And here he's compensated. So his butt is starting to shift forward. And we jokingly sometimes we call this the old white man's butt because it looks like their butt has disappeared. And it's just a compensation of long-term forward head posture and getting that. Because again, the body will follow where the head is. So you have sustained amount of time with that head forward, like, oh, head's forward, my butt is going to start shifting underneath. So we need to get the head weight back. So first of all, we unlock it using instrument and or drop adjustments, manual adjustments, and then get the head weights on them. So we start reprogramming the neurological pathways. Okay. So we look at these lateral postures from best to worst case scenario. You're getting these people that are over here in threes and where they now have flexion of the knees and ankles. That's a pretty chronic one. These are your very kyphotic older patients. Not real fun to deal with, but they can improve, right? Hope is lost when you throw the first scoop of dirt on the box. And that's something that I tell most of my patients. It's like they go to the MD, they go to different places, and they don't get any help. Well, when you do this system, you can, without a doubt, give your patients hope so that they can improve, their life can improve. Our first A-P postural pattern is compensated, meaning we got our heads pretty straight, we got a high shoulder, right? Eyes are level, shoulders are tilted, head is centered still with the body. If we drop that plumb line, this is called the number one posture. So you have a CD angle, usually on the high side. The shoulder rotation is indicative of where your pelvis goes. So you look at the patient from the front and the side, and you look at, okay, we have a high shoulder and it's rotated forward. You usually see the buttocks back on that same side if they're compensated. So we want to work on the lateral restoration of the curvatures. And a lot of times these will start to reduce on their own once you restore normal lordosis, right? When we do adjustments, we're typically focused on the neck here, where we're going to do Y or YA, which are manual traction adjustments, along with negative Z and instrument. Okay, and then we put weighting on, shoulder weight, head weight for sure, possibly hip weights as well. So number 2, excuse me one second, get a little dry. Posture pattern number 2. This is when you see the head tilted. Head and eyes are tilted. Shoulders are level or almost level, right? We don't see this. And I'll tell you a little tip when we get through these postures of how I teach my staff and how I've taught live seminars over the year how to look for and identify what is the predominant posture. So CD angle is usually on the low side. So if we were to bring the head upright, that shoulder would come up. So like a number 1 posture, it's going to be on the high shoulder side, or in this case, the low eye or the side the head is tilted to, right? Major displacement is at C4-5. We have to get that CD angle, which is a YA adjustment typically, to open up. Skull is not laterally compensated, and stress is usually noted in upper thoracic. So you get shoulders, you get the levator involved, traps. That tends to be really tight in the shoulders themselves. So number 3. Now this is very unique. In the general population, I think we see maybe 15% of the population would come out with a number 3. These are always going to have ligament damage. The head is shifted sideways on torso. There may be a little bit of shoulder unleveling, but typically not much. These are the hardest to fix because you've got typically a lot of ligament damage in the C-spine and or the upper back, upper thoracics. So CD angle is usually opposite now of the side of translation. You're always going to have compensation because if the head goes, guess what? Your shoulders go with it, which means you're going to create an uneven loading on the spinal column and or stress. So you typically have problems in all 3 regions, whereas like the number 1 posture is typically neck only. Number 2 is neck and thoracic, cervical and thoracic, and now you've got cervical, thoracic, lumbar, and pelvic issues. Typically, I would say, if I recall, research said about 83% of the time they have a TMJ issue as well that you're going to have to deal with. That's that. So typically have trauma. You know, if you do your flexion extension films, you're going to see, I would say in probably 75 to 80% of these cases, you're going to see a potential category 4 impairment rating on your initial films. Per the AMA Guides 5th edition, which you can get into that if you use it, great. If not, you might want to look up that and know what you're dealing with, because this is a person that they're going to be actively working at this for 2 to 3 years, and potentially they're going to have exercises due lifetime once you've made as much change as you can make with them. So hip deviations. So hip deviations are associated with AP, usually the lateral postures. So you're talking about number 2 and number 3 postures. You're going to have the hips involved, especially almost always 3, but usually 2 as well. Normal coupling of the low back and pelvic girdle is dependent on lordosis in the low back and the lumbar spine. Okay, so it usually rotates anterior in the side of low shoulder. So again, if we're compensated, if that shoulder drops down on my left hip is going to come up and forward just to get underneath. Okay, so hip rotates forward in X-ray, anterior hip usually also appears higher. So in the absence of ligament damage, everybody probably knows this, but you're going to almost always see an anterior superior ilium, right? If that's the case. We do a number 2 adjustment. We may do a retro as well on L5. You'll see that commonly. When you sit a patient down to take X-rays, you're going to amplify a retrolithosis or a spondy based on the pressure. And you also get some of the postural muscles that hold them upright when they're standing to relax. So we get a more accurate picture of what level of damage there might be in the lower spine. So initiating event. So a sudden applied force. How many times that has caused displacement of the head relative to the neck? How many times as kids, people falling, crashing bikes, gymnastics injuries, all these different things. They're basically a multitude of minor whiplashes that happen, but there's damage. And as we grow, the body doesn't fully heal itself. It doesn't fully return to normal function. So we have these things called righting reflexes. Our ocular, our inner ear, the joints of our neck, one for our head, and then for our body. We have 5 of them. The most powerful one is the eyes. So you'll see that when we do retraining for the patient, we typically have them in front of the mirror at first. And as they get stronger and they progress, we'll have them start exercising, doing tightrope walk, balance on the balance disc with, or on the air pad, the foam pad, with their eyes closed. And we're standing there with them, but we're helping them restore function is what it boils down to. Is again, it's a long process. You're dealing with these torn ligaments that have to kind of get a little break. And so by restoring strength to the musculature and nerve flow, you help the ligaments have some of the load taken off of them so they can start to shore up, and ligamentous creep comes into play and strengthening. So the lower spine displacements are mainly by the muscles, right? Our muscles move us. They do help with our posture and our structural integrity, but their main deal is to move, right? Reaction, active, involuntary, all the different movements that we do. So permanent low spine displacements cause hard and then soft tissue reorganization and changes. As I said before, structure dictates function. Hard tissue is always going to tell the nerve, the disc, where it gets to go based on where that hard tissue is at. So when we look at this, we're looking at that initiating subluxation event, which is skull locked and extend forward head posture. You see on this x-ray image, right? You look, the lordotic curve is totally gone in this neck, right? Skull is locked in extension. If you look at the arch of Atlas, that plane, you put a plane line through there and the suboccipital plane line, you will get suboccipital baseline, you'll see that is locked in extension, which causes cord compression right at the top of the spine, okay? Oh, lateral and A-P forces. So they can always translate the head, right? If you have a football player's hit from the side and they're not ready for it, you have this lateral whipping, a lateral impact, whiplash type injury, right? It causes ligament damage, whether it's micro tearing or sometimes, bad accidents, a complete rupture. But it definitely causes splinting of the muscles, and the body then just kind of locks into that position. And unless it's taken care of, will create long-term problems. How the compensated subluxation pattern occurs? Well, you have optimum on top, and on below you see this where spinal unit 1, which is skull, there's slight lateral alignment with gravity. The righting reflex, the eyes and the ears and all these different righting reflexes kick in, and they want your head to be level. So guess what happens? As the head comes level, like I'm here, my head comes level, I now have a high shoulder, right? My body is compensated. Well, I can't stay there very long. I'm going to have a high shoulder that, because it's my dominant side, comes up and forward. My pelvis down below has to twist, so my left ilium comes up and forward. And so I start to get a lot of torque in the spine. Coupled motion is lateral and rotation involved. And so if I rotate up here, I got to go opposite on the lower spine, which creates this torquing and displacement. You'll see these cause the rotatory shift of the shoulder girdle causes the lower thoracic upper lumbar, which is T7 to L3, to shift and correspond in the opposite direction. As I was saying, if my right shoulder comes up and forward, my left ilium then will come anterior and forward, or superior as well. The lateral and rotatory shift above cause L4 and L5 to rotate and shift in the opposite direction. So again, think opposite. Shoulders you see one way. In the absence of a very complete or ligamentous disruption, you are going to see this opposite displacement. This is where we start using hip weights, which is kind of cool. So you get all 3 areas given input, and you see the body start to unwind and line up more and more. Okay? Oh, this is a good one. Okay, so opposing iliums rotate coupled with displacement force from above usually causes sacral apex to flex on L5. So you'll see this posteriority or the retro in L5 is very common. If you take standing films and you don't see it, get a chair, get a rolling office chair if you haven't got an x-ray, the official x-ray chair, which is awesome. You get one of those, sit them down and take a picture, and you will see that there's a displacement of L5 almost every time. I mean, they took pictures of me standing. I had hyperlordosis, years of weightlifting, sat me down, and I had an 8mm L5 retro. So it made sense to me. I started to learn that when I would run more than a mile and a half, at about that mile and a half mark, my hamstrings would just tighten up because every step I was pounding that L5 disc and nerve roots. And consequently, what does the brain do? Hey, tighten things up, cause him a little discomfort so that he stops trying to hurt us. And that's how we're wired. Okay. Muscle splinting, first response to spinal injury, just what I was talking about. This tightening, I mean, the first thing people say, well, I'm always tight here. That's nerve pressure. That's displacement. That's a spinal displacement causing the soft tissue to be affected, therefore affecting function. Going back to structure dictates function, right? Okay, it restricts the movement of your shoulder girdle. If your lower neck is screwed up, the shoulders aren't working right. If your low back and your hips aren't right, your knees, the whole kinetic chain from your foot to your ankle to your knee to your hip are not working correctly. And you can put orthotics in. It might help a little bit, but it's not addressing the true root cause of the problem. Okay. You almost always see gait abnormalities. Excuse me. So what happens when our head goes forward? We have compression. All of our upper facet joints. Occiput locks down, affects vertebral arteries. C1 impingement. You see a lot of suboccipital and occipital tension type headaches with this patient, and they have lost rotational motion. Is not normal. Okay, so it is our job to educate not only our colleagues in our profession, but if we can educate the MDs, the PTs, the naturopaths, everybody in this whole healthcare continuum can be educated about this initiating event. That's our duty. We're the experts in this. This spinal biomechanics, form and function, structure dictates function. That's our backyard. This is where we have to teach those people in these other professions. Maybe it's through our patients, sending them back to them, say, hey, I got these kind of results. And that outweighed what the MD had referred them to PT, doing active stretching, massage. It's not that it's bad. It's just that they're not addressing the cause. Okay. Excuse me, I got off tangent there. But healthcare providers need to understand these far-reaching effects, is what I was just talking about, as well as the neurological features that affect this mechanoreceptor system. We have these different writing reflexes, as I talked about, that dominate the neck. The mechanoreceptors in the neck dominate the balance system and affect our gait, right, and our static posture and our balance. So the density of mechanoreceptors in human cervical spine is greater than at any other spinal level. So this is why there's so much happens when we give a cervical adjustment. It's more than just the popping, right? It really opens up nerve channels and allows proper feedback through efferent pathways and then afferent input. So we look at the joints of Luschka. Remember this from spinal anatomy. Typical vertebra, starting at the bottom of C2 through 6, are the only segments that have these lateral interbody joints. Okay, they allow flexion extension and they limit lateral flexion. Okay, and this is again why if somebody, for instance, I had a lady that got hit at 30 miles an hour right in the driver's door, right in front of the driver's door, and she had a traumatic brain injury, had a hard time forming sentences, loss of short-term memory, but she had essentially torn the ligaments on one side of her neck because of this impact. And it's not a fun one to deal with. So part of these joints, their job is to limit that, and it does a great job in the absence of injury. First four cervical vertebra, they are related to endorphin production. So we have patients that when they first start doing cervical traction, it may be a little sore, a little uncomfortable, but after they get through this corrective process, that is like the feel-good tool. It's like runner's high. They grab that thing and do like 10, 20 tractions just any time of the day, and they're like, oh, I feel better, because it boosts that endorphin, which helps our body deal with things that are noxious stimuli. It also initiates movement and neck. So when we put the head weights on, you start correcting that curve more effectively, right? And when you do it helps the spinal discs and ligaments to become more pliable. And then when you lay down the molding blocks, it helps to then cool and reform into our normal lordotic curves. If we don't have normal, let me go back. If we don't have normal endorphin production, we tend to be more pain sensitive. The patients that are not moving, therefore they're not getting this normal endorphin kick with neck motion, they tend to be more sensitive to pain. So a couple fun little things that our upper cervical spine does for us when it functions right. You look at this. C1 through C4 also have muscle and eye control, posture, balance, gait, our ability to taste, smell, and to talk, right? I'm subluxated right now. I need an adjustment. But your TMJ tension, I mean, you can tell that by simply doing a TMJ test to see if you can open your mouth. Painful trigger points in the jaw muscles, right? Your ability to do coordinated movements, your dexterity, right, with your hands, fine motor skills. Vertigo is typically when we have problems in that upper neck. Okay, so loss of lordosis, or part of it, after age 12, we lose the blood supply to the discs, which means our nutritional delivery system to the spinal discs has got to be through motion, right? We have to have motion in there. So if we lose any of that, we affect everything around it. The thoracic spine, the shoulders themselves. It reduces your vital lung capacity by up to 30% for every inch forward you go center. That was something that was put into Callier's studies and work. I believe it was at University of Southern Cal. But get the brochure, you'll have all the details, okay? So in conclusion here, we're getting close to the end. The initiating event subluxation displacement results in skull and C1 in extension, sometimes in flexion, but over 80% of the time it's in extension. Forward head posture and loss of normal lordosis. When the skull is locked out of flexion or extension, the head is forced into a forward head posture, right? Your ocular writing reflexes want to bring the head up. So there we go. Over time, that loss will become kyphotic and or an S-curve. And those are really fun to deal with trying to get out of there. You lose that normal couple motion. The skull, the cervical and upper thoracic spine, they tend to start to roll in. Loss of function. Breathing, ability to breathe is decreased. Again, you can measure that quickly with spirometry. And make it kind of a game, especially if it's a kid. Say, hey, you did this. You should be here, so I bet you can't get it here. Most kids, when you tell them, I bet you can't do something, they will respond. Adults usually don't have to play games. They kind of get it because they realize there's an end to this thing we call life. Okay, so we want to make sure that we restore normal function or as close to normal as possible. Our initial exam determines the number and severity of problems with that patient. That comes from digital posture analysis, our structural x-rays, then the analysis that we do. Okay, then we can say, okay, we test them. Their second visit, we do a stress evaluation. We put the body weighting system on that's appropriate to that person. We take x-rays with it on. Then we can accurately predict approximately how much reduction or of the problem or improvement of the spinal position we can make, and that can be permanent in 4 to 6 months. They have to start doing their homework, right? They have to do the things you ask them to do. And that's why I tell patients, if you do your treatment program the way it's laid out, this is the type of permanent results you will have in this many months. And if they do it, it happens. So that's kind of the fun for me, is that when we tell them, we show them that they can improve. It's not just my opinion. It's like, here's this hard data that we show you, and here's how much we can do. And then when they see it, and not only do they improve, but their life changes. They feel better, right? I got a long one here, but I won't read it. But you can go to our website. We have all kinds of cool testimonials of people with chronic pain issues. And because of this system of care, which starts with identifying postures and where the deficits are, those people's lives have changed. Kept them out of surgery, not just pain, that they have tools now to have an entirely different life than they were going to have. So that's what's really cool about doing this system, is that there's predictable results, and you can say with certainty, because you studied, you know the posture, you've learned the weighting system and what it takes, and you can have permanent tissue change, which means, hey, these people will be patients for life unless they die or they move away, because you helped them when nobody else could. But it starts with this foundation of identifying what started this. Why is this head here? We need to get it back here. And then looking at the posture, appropriately weighting them, and getting them functioning again, getting the body back in harmony. So it's important to note that you have to get to a certain point of lordotic correction before the AP correction will be long lasting. As it says here, at least 60% of the correction. So normal cervical lordosis should be 45 degrees. So I think you got to get to at least 27 before you start seeing long-term permanent changes that will not go away, barring a new injury. Or they just stop doing everything, they disappear. But those people, they just disappear. We don't see them again. Doesn't happen very often though. You have to detect, and you can show them how much this is going to change by doing your stress evaluation. And again, it's my opinion. I've been doing this work for, 16, 17 years. But you can show the patient where they can be, and they will feel better. It's a process though. So to everybody who wants to live a long, active, and energetic life, not too many things are more important than your posture. And I appreciate your time. Get in here, get into the Pettibon system, learn these things. It will not only change your patients' lives, but it will change your life. And you'll have a lot of fun in practice helping people change. So, all right, guys, take care. Thanks for your time, and we'll see you soon at the next one. There's a few more slides.
We hope you enjoyed today's webinar. On behalf of the Pettibon System, thank you for joining us. Please follow us on Facebook, LinkedIn, and Pinterest. Links to those are in the resources button. Check our social media and website for upcoming webinars. Again, on behalf of the Pettibon System, thank you for joining